You know how sometimes the most important questions are actually deceptively simple? Like, what is diarrhea? It sounds like such a basic medical term, doesn't it? But today we're taking a deep dive into exactly why that, well, seemingly fundamental definition has these profound, widespread implications for millions of children globally, especially in low-resource settings. Our focus is a really critical review. It was published in the Journal of the Pediatric Infectious Diseases Society, and it meticulously examined how pediatric diarrhea gets defined in these crucial contexts. So our mission today is really to unpack why this definition isn't straightforward at all. What are the different approaches people are taking? And maybe most importantly, why getting it right is absolutely crucial for saving lives and, frankly, allocating precious resources effectively.
Yeah, it's truly fascinating, isn't it, how a clinical term we might just take for granted, when you apply it across incredibly diverse populations and for all these varied public health goals, it just transforms into this really nuanced challenge. And this isn't just some, academic debate. For you listening, this directly impacts how we understand the true burden of disease, how we measure the success of public health interventions, and ultimately, how resources get prioritized in the communities that need them the most. The stakes for getting these definitions, well, precise, they're just incredibly high.
That's a really powerful way to frame it.
Right.
So, okay, let's unpack this then. Why does it matter so much how we define pediatric diarrhea, especially in these low-resource settings? You'd think there'd be a universal understanding, right?
Well, the core issue really is that different definitions lead to wildly variable estimates right across the board. We're talking morbidity, mortality, treatment coverage, even the very associations we find with risk factors and health outcomes. Imagine trying to get a clear picture of a problem when the lens you're viewing it through keeps, well, shifting.
That's a staggering potential for error.
Mm.
Just huge. Beyond just the numbers, what are the sort of systemic consequences when these fundamental definitions diverge like that? How does this ripple effect impact actual public health initiatives and the outcomes?
Oh, it creates a systemic cascade, yeah. This misclassification, it can lead to inaccurate prevalence estimates, for one, which then directly impacts how and where resources are prioritized, sometimes, completely inappropriately. It can also lead to erroneous attribution of causes or health outcomes, which makes it incredibly difficult to confidently pinpoint what interventions are truly effective, or even why certain health problems persist.
Can you maybe give us a concrete example, something from the source material that really illustrates this real-world impact for us?
Certainly. Consider a community-based study in Nigeria. When researchers compared maternal reports of diarrhea against lab-observed stool consistency, the diarrhea prevalence estimates, they varied by almost 100%.
100%.
Yeah. Depending on the specific definition used, the prevalence ranged from 4.8% all the way up to 9.5%. Think about that for a second. How can public health planners effectively provide, say, oral rehydration salts or improve sanitation with that kind of uncertainty in their baseline data? A nearly 100% variance is, well, profoundly unsettling.
That's a monumental difference. It really is.
True.
How does such a wide margin of error directly translate into, say, misallocated resources or maybe flawed intervention strategies?
Exactly. The consequences are absolutely tangible. Another powerful example comes from a study in Kenya. It showed that the odds ratios for the effect of lacking a latrine on subsequent diarrhea range dramatically. We're talking from 2.2 up to 13.5.
Wow, that's a huge range.
It is. And the statistical significance of that association, it completely depended on how diarrhea was defined. So this raises a really critical question. How can we confidently identify effective interventions if our baseline measurements for the problem itself are so inconsistent? For you, this means that even seemingly solid public health data, the kind that often guides policy and funding, well, it might be built on a surprisingly shaky definitional foundation. It really challenges us to look deeper than just the numbers themselves.
Okay, so if this definition is so critical, who exactly is doing the defining? And what are the common approaches people are currently using, to try and get a handle on this challenge?
Right. The review identified three main categories, sort of sources for these definitions. There are clinical practice guidelines, then programmatic documents, and finally, research studies. And interestingly, each category tends to approach it with slightly different priorities and different methodologies.
Okay, let's start with clinical practice guidelines then, like maybe those from the World Health Organization.
Yeah.
What's their common approach? How do they try to capture this elusive definition?
Well, clinical guidelines, particularly from the WHO, they often use a blend. A mix of quantitative measures, like the actual number of loose or watery stools, combined with a more qualitative consideration. Thinking about what's normal for an individual child. For instance, back in 1988, the WHO consensus definition described it as usually defined as the passage of 3 or more liquid motions during a 24-hour period. But, and this is crucial, it added, however, for exclusively breastfed infants, the definition is usually based upon what the mother considers to be diarrhea.
Interesting. So even back in '88, the WHO recognized that just counting stools wasn't enough, especially for breastfed babies. How significant is that qualitative element, what the mother considers diarrhea? How important is that for getting an accurate picture?
Oh, it's extremely significant because it acknowledges that individual variability, children aren't all the same. And the current WHO definition still reflects this idea. It says, the passage of 3 or more loose or liquid stools per day, or more frequently than is normal for the individual, it also clarifies. Frequent passing of formed stools is not diarrhea, nor is the passing of loose, pasty stools by breastfed babies. However, it's worth noting, some other WHO-sponsored guidelines can be a bit less specific. Sometimes they rely solely on the caregiver reporting an aberration from normal, or sometimes they just stick to the 3 or more loose stools in 24 hours without really fully integrating that normal for the individual piece.
Okay, so that's the clinical side. What about programmatic definitions? Like the ones used in those big surveys, the Demographic and Health Surveys, DHS, or the Multiple Indicator Cluster Surveys, MICS. How do they handle this, given they have such a broad reach?
Yeah, these programmatic approaches, just by their nature, they have to rely heavily on caregiver recall. It's practical. So, for example, the 2015 Phase 7 DHS survey just asks, has meme had diarrhea in the last 2 weeks? And if the respondent isn't sure, the interviewers are prompted to clarify using the quantitative bit, 3 or more loose or liquid stools per day. MICS is pretty similar. It also provides that definition. 3 or more loose or watery stools in the last 24 hours or more loose or watery stool that are normal for individual. And it explicitly states that breastfed babies might have multiple loose stools that aren't actually diarrhea. So again, that nuance for breastfed infants pops up.
Right, caregiver recall seems practical for these large surveys, definitely. But isn't it also potentially prone to some of the same biases, like cultural or linguistic differences we touched on? What are the sort of inherent trade-offs there?
You're absolutely right. It's a necessary trade-off you make for scale, but yes, it introduces vulnerabilities, definitely. And that really brings us to research studies, because here, the variability, it truly becomes stark. The review looked at 94 research studies in detail, and they found, get this, 54% used only a quantitative definition, like just a specific number of stools.
Just over half.
Yeah. Only 10% used only caregiver perception, what the parent thought. Then you had another 12% that used either a quantitative number or caregiver perception. And 8% used both, together a quantitative cut point and caregiver perception. And frankly, what's kind of astonishing is that 14% of the studies reviewed, they didn't even define diarrhea.
Wait, 14% didn't define it at all. That's almost unbelievable. What are the real-world consequences of just leaving it undefined like that? For science, for comparing studies?
It's a huge problem.
Yeah.
It makes comparison between studies, replication, meta-analysis. It makes it incredibly difficult, sometimes impossible. Now, when a quantitative definition was used in research, the most common one by far was 3 or more loose stools in a 24-hour period. This definition accounted for 65% of the studies that actually used quantitative definitions, which was about 35% of all the research studies they looked at.
Yeah.
So what we're seeing is a real mix of approaches and this clear tension between a strict number of stools on one hand and a caregiver's personal judgment on the other, which naturally raises the big question, which one is actually right?
Yeah.
Or maybe, which one is better?
Right. And to figure out which definition is best, you usually need something to compare it against, a gold standard.
Yeah.
But the complexity just seems to intensify when we look at the different benchmarks people have used as this gold standard, doesn't it? It's not straightforward.
Absolutely. That's always a critical point in these validity studies, establishing that reliable gold standard. What are you measuring against? And one of the most commonly cited sources for that 3 or more loose stools definition is from a 1991 Bangladesh study. But interestingly, it actually used caregiver perception as its gold standard.
Okay, that is fascinating. They prioritized the subjective experience over just counting stools. What was their reasoning behind that decision?
Well, the researchers argued pretty logically that caregivers are just uniquely familiar with their own child's normal stool patterns, day in, day out. Therefore, they figured caregivers would be best equipped to identify an aberration, something different that might signal a pathological or, clinically relevant event. And against that gold standard caregiver perception, a definition of 3 or more loose or watery stools or 1 or more bloody stools in 24 hours actually achieved the best balance. Sensitivity was pretty good at 78%, and specificity was high at 96%.
Okay, so in that case, caregiver perception as the benchmark worked reasonably well. But you mentioned there's varying agreement across studies. So what happened when other researchers tried to pin down a gold standard?
Right. Well, later in a study in Nigeria, they essentially flipped the script. They did the opposite. They used the quantitative definition specifically, 3 or more liquid or semi-liquid stools during the past 24 H's as their gold standard. And compared to this quantitative definition, caregiver perception had a surprisingly low sensitivity, just 36%.
Only 36%. That's low.
It is. A staggering 64% of children who met the quantitative definition, the 3+ stools definition, were not considered to have diarrhea by their caregivers. Now, the specificity was still high, 96%, but this tells us something really crucial. It showed caregivers were less likely to report diarrhea in very young infants, under 2 months, and in exclusively breastfed infants, even when those children technically had 3 or more liquid stools, according to the count.
That's a massive divergence, a real disconnect. And then there was the Kenya study you mentioned earlier. What was their gold standard, and what did that show?
Right. That study looked at children under 3, and they used yet another gold standard, actual direct observation of stool consistency by a trained observer, someone looking at the sample. In that scenario, caregiver perception had very low sensitivity, just 14%, when compared against a quantitative definition. But interestingly, it had a much better sensitivity, 79%, when compared against the trained observer's assessment of consistency.
So, wow. We've got caregivers, quantitative counts, and trained observers, all yielding these wildly different results depending on what you compare them to. Given these conflicting gold standards, maybe one of the most intriguing findings is why caregivers' perceptions might diverge so much from these clinical or quantitative definitions. What's really going on there? Is it just misunderstanding, or is it something deeper, maybe about how different cultures perceive illness?
It often seems to be more profound than just a simple misunderstanding. Yeah, caregivers might intuitively know, that frequent loose stools in young, exclusively breastfed infants are actually normal for their child, not necessarily a sign of illness. And we know breastfeeding is protective against diarrhea, right? So a higher frequency in these infants doesn't always equal clinical risk in the caregiver's eyes. However, there are definitely significant downsides to relying solely on caregiver report. You have to acknowledge that. They might miss milder cases, for instance, that a quantitative definition would pick up. And their recognition, that perception, can also be influenced by things like education level, whether they're in a rural or urban setting, and crucially, as you mentioned, language. The review points out that in one region of Sierra Leone, for example, the local terminology for diarrhea included something like 11 different terms across 4 different languages.
11 terms.
11 terms. And each one had a slightly different meaning, a different interpretation of the type and severity of diarrhea. So this kind of linguistic and cultural variability, it can lead to highly erroneous prevalence estimates and huge issues with reproducibility across different contexts. It's kind of like trying to build a house, right? But half the builders are using inches, the other half are using centimeters, and some are just sort of guessing based on what feels right. No wonder the whole structure ends up feeling a bit shaky.
That analogy perfectly captures the challenge, doesn't it? So, okay, we've seen the struggle to nail down a universal gold standard. Let's maybe break down the practical pros and cons of these different definitional approaches for you, our listener, so you can really understand their strengths and weaknesses in practice. What about the advantages and disadvantages of, say, purely quantitative definitions, like the 3 or more rule?
Sure. Quantitative definitions, like 3 or more loose stools in 24 hours, they certainly have their strengths, no doubt. Their primary advantage is that they are highly comparable. You can compare results across different studies, different regions, which allows for more consistent data collection. That's valuable. And they might also serve as a sort of proxy for total stool volume, which could maybe inherently measure severity to some extent. However, the cons are pretty significant too. As we've discussed, they often don't account for individual normal patterns, which can lead to an overestimation of true diarrhea, especially in those young or exclusively breastfed infants whose normal stool frequency is just naturally higher. Plus, they rely heavily on caregiver recall of exact numbers, which, as we know, is vulnerable to bias. things like low literacy or numeracy levels, and again, that language variability issue.
Right. And what about the other method, visual inspection of stool consistency by a trained observer? What are the practicalities there?
Visual inspection. Well, it can be quite advantageous because it's potentially more reproducible. You can standardize it with proper training. However, it doesn't account for frequency, how many times it happens. It doesn't capture the total volume of stool produced or how long the episode lasts. Those are important factors. And furthermore, there are just significant logistical and financial constraints. It's simply not feasible for large-scale community surveys. Plus, by the time a sample is collected and actually observed, its consistency might have changed anyway, so you could lose valuable data. And, like the quantitative definitions, this method also often fails to account for individual normal patterns, age, diet, or feeding methods.
Okay, so it really sounds like there's no perfect single definition that just covers all the bases easily. Does the context in which we're looking for diarrhea, does that also play a crucial role in figuring out which definition might be the most appropriate?
Absolutely. Yeah, if we connect this back to the bigger picture, the context where a definition is applied fundamentally influences its validity, its accuracy. For instance, the accuracy of a definition is often higher when it's applied in healthcare facilities, places where people are already seeking care because they feel their child is ill. That's often different compared to a community surveillance setting where the population isn't necessarily presenting as ill, and detection really depends on active case finding.
That makes intuitive sense, yeah. What about the specific type of pathogen causing the diarrhea? Does that factor into choosing the right definition too?
It does, or at least it should. For pathogens that produce really profuse, watery, secretory diarrhea, think rotavirus or Vibrio cholerae, a definition based purely on the number of loose stools might actually be the most optimal measure of severity and that critical fluid loss. But for other causes, other bugs that result in maybe less acute fluid loss but are associated with more chronic issues like Cryptosporidium and its link to linear growth failure stunting well, then maybe a definition that includes the mother's perception of the child's overall health might be more appropriate, because it captures that broader impact on the child's well-being.
And I imagine the ultimate goal of the diagnosis itself must heavily influence the definition you choose.
Precisely, yeah. If your goal is to identify children who are at immediate risk of dehydration, maybe to assess, say, oral rehydration solution coverage in a program, then you need a definition that maximizes sensitivity and specificity for that specific outcome, dehydration risk. However, if your goal is different, like studying the long-term link between diarrhea and malnutrition, then you need a definition that's optimized to distinguish children with the highest and lowest likelihood of experiencing those long-term consequences. And of course, just to complicate things further, you have non-infectious causes of diarrhea, things like inflammatory bowel disease, maybe recent antibiotic use, or even secondary consequences of other infections like malaria and dengue. All these things further complicate these definitions. It really feels like trying to hit a moving target sometimes, doesn't it? Especially when the rules of engagement, the definitions themselves, keep changing. What does this mean for the fundamental reliability of the public health data we encounter every day?
So, okay, we've clearly identified this systemic problem. We've examined all these varied approaches people are using to define it, and we really understand the significant challenges involved. What does this all mean, then, for improving public health efforts, for improving outcomes, especially for vulnerable children? Where do we go from here?
Well, the core conclusion of the review is pretty stark, really. These persistent differences in definitions, they severely limit our ability to accurately quantify disease burden. They limit how we measure treatment coverage, how we understand associations with risk factors and health outcomes, and ultimately how we assess the true impact of our interventions. And a quantitative definition alone, as we've discussed quite a bit, often just doesn't fully reflect a clinically relevant disease state. It misses nuance.
That's such a critical point. So what's the proposed solution? Or maybe the path forward, at least for now, to try and bring some sorely needed consistency to all this?
Well, until further, more rigorous validation studies are performed, the review suggests that research settings in particular could systematically use a definition that requires both things. Both a minimum frequency threshold specifically, that familiar 3 or more loose or watery stools in a 24-hour period, and the perception by a caregiver that this event actually constitutes an aberration from normal for that individual child. And here's the truly startling part, maybe the hidden irony buried in this deep dive. The path forward, this sort of new proposed solution, it actually mirrors wisdom from decades ago. This combined approach, which was recognized way back in early WHO guidelines, is actually inconsistently applied in practice today. We've kind of effectively come full circle, haven't we? Rediscovering a balanced approach that somehow got lost in translation over the years.
That's incredible, really. A solution that was kind of there all along, now being re-emphasized, that's quite something. Beyond just using this combined approach now, what does the future hold for defining diarrhea more effectively, maybe with even greater precision down the line?
Looking ahead, we really need a set of truly standardized definitions. Definitions based on events of actual clinical relevance and definitions that directly target pathways for intervention, making them more actionable. There's also likely a very promising role for biomarkers. These are biological indicators. They could signal gut health issues like environmental enteric dysfunction or inflammation or shifts in gut bacteria, or they could even directly measure fluid loss. These could potentially help us develop much improved clinical definitions, more objective, more universal. And finally, studies are just desperately needed to determine age and feeding status standardized stool frequencies. Specifically in these low resource settings, this would allow us to create more accurate subgroup specific definitions for children, something that's really lacking in our global data right now.
Ultimately, it feels like this all comes down to accuracy, doesn't it? And impact. Getting these definitions right isn't just about, good science in the abstract. It's really about making sure resources go where they're most needed, and that we accurately measure progress for vulnerable children worldwide. It's fundamental. Wow. What a deep dive that was into something that, honestly, on the surface, just seems so simple. Who knew diarrhea could be so complex to define effectively? We've seen how profoundly these variable definitions can skew public health data. We learned about all the different ways diarrhea is currently defined, from those strict numbers to that invaluable caregiver perception. And we've explored the real challenges finding a truly universal gold standard.
Yeah, and if we connect this to the bigger picture one last time, it just underscores how critical precision in measurement really is, even for the most basic health indicators. The path forward, it seems, involves carefully integrating both objective measures and the invaluable lived experience of caregivers. To build definitions that truly reflect clinical reality and also programmatic needs. That way, we can ensure our efforts are effective and truly make a difference.
But maybe the next time you hear a statistic about a global health challenge like childhood diarrhea rates, take a second. Consider the hidden definitions that might be lying beneath those numbers. It might just make you wonder, how many other critical health issues are we potentially miscalculating or maybe misunderstanding simply because we haven't agreed on what we're actually measuring? What stands out to you about how these definitions shape our understanding of health challenges? We really hope this deep dive has given you a whole new perspective.